everyone. My name is Jessica Formean-Starks, and I'm clinical faculty here at Boise State University's Department of Respiratory Care. I'm here with a very special episode of our Go Bronchi podcast, and we're doing something a little bit different this time. Today, I want to share with you a recording of our live journal club meeting. These respiratory care journal club meetings are something we've been doing for a few years now, but we know that scheduling can be difficult, especially since we have people who want to join us from all over the country. So we've decided to go ahead and start recording our journal club meetings so that we can share with all of you. We're planning to do one of these meetings every quarter, and we'll be sharing them here on our usual podcast feed. So keep following along if you want to see future episodes. And without further ado, I'm going to go ahead and get over to the meeting. I hope that you guys enjoy it as much as we did.
Jessica, wonderful. Thank you for remembering. The Medical Literature Club, formerly known as the Journal Club. And we changed the name of this club for a specific reason. I'm one of your co-hosts, Jhaymie Cappiello, and I'm sitting here with...
Hi, I'm Jessica Starks.
She's our other co-host. We're both professors in the Degree Advancement Program. And thank you for joining us. We have an outstanding piece to discuss tonight. I do want to put in a plug for our Go Bronchi Spotify podcast. There's some excellent pieces coming out from all three of our departments about respiratory care. The latest one was October 7th, tracheostomy management from Professor Zemke. Also, we're going to be publishing these journal clubs, these medical literature club recordings on the podcast as well. So if you have any friends, colleagues that you want to go Bronchi proud, you want to share this information, be our guest. All right. So quick overview of what we do with this club. We increase awareness of the subject reviewed. We demonstrate the evolution and development of medical knowledge. We look at the piece's validity, value, and applicability. And this is designed actually to be professional discourse, to get together, to discuss things that, hey, we have difficulty having these open conversations at work because we have work to do. Maybe we are not on the same page as other people, but this is a part for respiratory therapists to really get together and have these chit chats relative to the subject. So it's a great networking opportunity, and thanks for joining us. Tonight, we're going to be going over this article, Revisiting the Common Canister Protocol by Mr. Robert Bayliss. Thank you for joining us, Mr. Bayliss. It's here says Department of Respiratory Care, but he's actually out at UC Davis. More from Mr. Davis later. All right, so Common Canister Protocol. For those of you that are familiar with it, bear with me. For those of you that aren't, the patient-specific items involve the spacer and the actuator, right? The spacer and the actuator, these are patient-specific items, and they're not part really of the Common Canister Protocol. What we're actually referring to is the actuator going from patient to patient, and as long as we're practicing good hand washing technique and we're donning gloves and we use a hospital appropriate disinfectant and we're cleaning this actuator well, this should not cause cross-contamination. So there are many institutions that use Common Canister Protocol. There are some that shun it. Pluses and minuses, this is a decision that we don't really have best practice yet. Note that there's no Joint Commission guidelines. There's no regulatory agency guidelines on what has to be done. So puts us in a little bit of a quandary. Well, we're respiratory therapists, we're experts in the inhalation administration route. When we look at medication administration, we have to consider the drug, whether it be generic or name brand or trade name. We have to consider the route, IM, IV, oral, inhalation, nebulizer, dry powder, all these things we have to consider, and the dose itself, because these things combined is what's going to cause this physiologic effect. So, all right, we have things to consider to produce a physiologic outcome, but we need to also consider that in order to deliver the medication, it needs resources, and those resources come in the form of cost and in workflow. So doses, drug, and route all impact cost and workflow, and we want our resources to balance what we do at the bedside. All right, the outcome is important. All right, evidence-based medicine says we have to do best practice, we have to do patient values. Well, we have to also consider part of that evidence-based or best practice is considering, are we doing the right thing for the environment we are in? So we need to be sensitive to resource allocation. So I came upon a piece done by Caraway, Davis, and Klinger. It was an abstract presented at Open Forum back in 2021, the Respiratory Open Forum, who did a piece on cost savings related to transitioning common canisters to nebulizers, all right? So during a pandemic. So there were issues with nebulizer therapy, cross-contamination, getting respiratory therapists infected, yes. But what they did is a really pharmacy-based piece of work. They took patients that were to get MDIs and automatically switched them on admission to nebulizer therapy. What pharmacy realized, or what these therapists don't all realize, was that if they took the patients that were admitted and ordered on MDI therapy, sorry, I got that backwards, they switched them to nebulizers. What they realized is that after implementing the nebulizers and not using the inhalers, they saved about $31,000. And they were calculating this based on the amount of wasted medication thrown out in the canisters that they would have used. So they looked at over a year how many nebulizer treatments they give. They calculated out how many canisters they would have used and how many they would have wasted. And they came out with, by not using the canisters, by not using spacers, they're estimating about $31,000 is being saved. So their philosophy, or their institution, said, we're going to go with this, or we think this is a good cost-saving measure to just give all patients nebulizers and no MDIs. All right, interesting thing about this piece, and one of the drawbacks I thought it was, there's no cost comparison on its impact to respiratory therapy. So we know nebulizers take more time. We know nebulizers are more costly than a metered-dose inhaler treatment. Also, we have no end. We have no number of how many patients, how many treatments were nebulizer versus inhaler. So good information there saying that this worked. Good information knowing that we can save money, that the canisters, there is a waste regarding canisters. But we look at another piece that just came out fairly recently, about a year ago, where they did internal analysis on transitioning patients from nebulizers to MDIs, just the opposite of the last piece we looked at. Now, this is a big full-length article, and if you copy this down, you can read the article yourself, or just send me an email, I'll send it to you. But they looked at 552 general ward patients about a year's time. It's obstructive lung disease, so it was probably similar medications to the one we just saw in the last article, or the last abstract. And they found that they looked at a $20,000 savings when they transitioned patients after 24 hours from nebulizers to MDIs. So the last piece I just showed you said switch from MDIs to nebulizers, save money. And this piece says switch from nebulizers to MDIs, save money. Well, they're both valid pieces, or they're both valid questions to ask. They had good information. The takeaway is, if you decrease MDI canister waste, you'll save money. And nebulizers are more costly than MDIs. So we're in a quandary. Is this a pharmacy versus respiratory battle? I think the answer is going to be found in what Mr. Bayliss is going to present to us. So with that, we'll move forward, and I'll let you know why I chose this article. Medical literature, yes, we know where it's found. It's found those beautiful websites, those paperback things. It's peer-reviewed. It comes up in IMRAD format, but it's also found within your own institutions. Good quality improvement processes, good quality assurance processes, that's good medical science. It's not so much if it's published, it's how the work is done. That's what's important, all right? The things that you learn about what causes validity, wherever you find a report, a result, look for those elements of validity, and that will establish. Just because a paper is in a journal, it doesn't mean it's valid and generalizable. So look to where you can find the information, and I think this piece gives us some great information, even though it's not published yet, right, Mr. Bayliss? Okay.
Correct.
So respiratory therapist driven, this is a grassroots piece of work. This was done by an individual respiratory therapist who saw an issue. Respiratory therapists are experts on inhaled medication, right? So I think this is an excellent piece because it's a grassroots respiratory therapist driven idea. It's not a top-down issue. It also involves cost, right? When we're looking at resources, infection control and risk management. This piece actually extends or helps highlight that interdisciplinary collaboration, because no matter what the results were of this work, in order to generalize it or implement it or actualize it into practice, it needs to combine the other disciplines relative to infection control and risk management. So it's a nice piece on how our work impacts other disciplines. And then change management. We can't make change unless we understand how it happens. It's a plan, do, study, act cycle. You can read these cycles, you can read what CDSA cycles are until you're blue in the face, but unless you see actual that implementation of process management, which this piece does a great job describing, that'll help you really embrace change management, because that's how we make things better. All right, and with that, here's the article, and take it away, Miss Jessica.
All right. Well, thanks for that excellent introduction, Jhaymie. I think I'm going to have you progress the slides for me, though. So if you wouldn't mind moving on to the next one for us. All right. So a little introduction to this piece of work. And as we've mentioned, we have the author himself here with us as well. So feel free to chime in if I'm getting anything wrong here, Mr. Bayliss. But nonetheless, as we know, the COVID-19 pandemic highlighted medication shortages nationally, globally, really. We were seeing a lot of medications being unavailable when we needed them. And today we are still seeing similar instances, especially with things like IV fluids, post-hurricane, right? We're still feeling those impacts. And as Jhaymie explained through this evidence as well, common canister protocols have been shown to reduce medication waste. The typical procedure when a patient is discharged from the hospital for a place where MDIs are truly single patient use, often what is left in the medication is simply thrown away. In some hospitals, they're able to send it home with the patient, but in a lot, they are not. So we do have quite a bit of medication waste without a common canister protocol. And as Jhaymie also mentioned, it can reduce associated costs. And we'll talk about that more when we get into the meat of this article. What this study really looked at, though, was about the concerns for contamination, because that is really one of the big things that we have to consider when we're talking about common canister protocols. Is it safe, especially when we're talking about an environment like a COVID-19 pandemic? We know that MDIs tend to be a little safer for the therapists and healthcare practitioners who are working with the patient because MDIs create less aerosol. But again, we have to make sure that we don't get cross-contamination. And so that's what this study really set out to do. This was a single center quality improvement project, as we'll see. And if you wouldn't mind moving on, Jhaymie, we'll get into some of the details. So they trained 9 individual respiratory therapists on the specific procedure that they wanted to use for this study, involving how they were going to disinfect and how they were going to test for biomatter afterwards. They had these split up into 2 canister groups. The control group involved new unused MDIs, and the intervention group involved post-sanitized in-use MDIs. So we're talking here about the common canister ones that after they were sanitized and having been used with a valved spacer. The primary outcome that they looked at here was something called relative light units, RLUs. And this, to my understanding, is really an ultraviolet way of detecting whether or not there is biomatter on any particular surface. And so biomatter can include things like bacteria, viruses, things like that, anything that is technically alive, right? And so that was the primary outcome of this study, is checking biomatter levels of these canisters and comparing them, the common canister use ones compared to those that were previously unused. And then some secondary outcomes that they looked at as well, did a little comparison of the 2 cleansing wipes that they have at that institution, and a little bit about staff feedback regarding the teaching effectiveness as well. So what did they find? As mentioned, we've got these 2 different groups here. The control was the unused MDIs. They ran 186 tests on 9 total MDIs. And then for the intervention on those post-sanitized common canister MDIs, they ran 115 tests on 8 of them. And what they looked at was again, RLU. So this is those light units for detecting biomatter. They took the mean of all of these readings. And for the unused MDIs, they found a mean RLU of 23.1. And for the common canister ones, the mean was 51.2. They also did have a couple of tests that were considered failures, I believe because the RLU was too high. The mean for these 2 failed tests was 453. But these 2 tests out of 115 plus 186 represent only 1.7% of the sample. So we had a very small amount of these common canisters that failed the infection control test. And it was noted that these 2 failures were also done by the same clinician. So it could have been something about user error or a one-time issue as well. So things to note. And then for comparing the two different wipes, they used Oxyvir versus the standard Sani wipe. And we've got our N numbers here, 58 versus 56. And what they found was a slightly more RLU, slightly higher RLU for the Oxyvir wipe compared to the Sani wipe. So we're looking at a mean of 57.6 compared to 44.7. However, the p-value for this difference is not significant. It's 0.32, indicating that while, yes, we do technically see a difference here, there's no guarantee that we would see something similar in the future necessarily. So a little bit of discussion, and I don't want to put any words here in Mr. Bayliss's mouth. So again, feel free to jump in. But what I took from the discussion section of this article was first and foremost that appropriate levels of disinfection for common canister has not been established. There is a little bit of existing literature, but again, we don't have a standard. We don't have anything to really compare against. And so that makes things difficult in really evaluating how clean something is and how clean something needs to be. And again, the disinfection is also dependent on the contact time with the germicide, so how long has that germicidal liquid been in contact with that biomatter? Has it been long enough to actually kill it? And so, of course, this is going to require having effective workflows in order to implement so that we make sure that everybody understands how, when, and why we are disinfecting these things. And you're also going to need to do some follow-up with that as well. So these are things to keep in mind if you are considering implementing a common canister protocol. We've already talked about how common canister reduces medication waste, and this can be especially helpful in times of shortage. Plus, it can just be general practice, right? We don't want to waste medication that could still potentially be used. We also discussed that MDIs produce much less aerosolized matter. And so this involves reducing the exposure of our respiratory therapists and other healthcare practitioners who are treating that patient. And so, of course, in the time of a pandemic or, we're in flu season right now, these are things to consider. Mr. Bayliss did highlight one particular source that I also wanted to highlight here, in that they found that prep time was shortened by 98%. This is huge, much less prep time with an MDI compared to a neb, and the delivery time was reduced by 48%. And this is not surprising. We know that it takes a lot less time to deliver an MDI than it does for a traditional neb. But they have a p-value here of less than 0.01, which indicates that these are statistically significant findings. This particular study did not find any significant difference in disinfection rates for the two different wipes, so that's something to keep in mind as well. But it also indicates that effective training and monitoring are feasible in a department of this size. We do have some limitations, of course. This is a small study, relatively small N for what we would typically prefer to see, and it was a single center. And so, of course, that limits our ability to generalize these findings. It was also a short time period for the study, but we have to keep in mind that this was done as part of graduate research that had some time constraints. And so we'll give you some grace on that for sure. But really, the biggest limitation to me is really understanding what the clinical significance of RLU really is. Again, we don't have those standards established to be able to tell what is clean enough, or what even really our goal should be in terms of what's a cutoff for acceptable RLU. And also, are there better ways to assess disinfection? I think of things like culture, and there are other real-time tests available as well, but there are cost and feasibility concerns for this too. So I think this study does demonstrate that the particular device that they used is at least feasible and relatively manageable for your regular respiratory therapist to handle. And again, we don't have those disinfection standards established, so this limits our ability to interpret. But in conclusion, we have shown here that common canister protocols can be beneficial for multiple reasons. There may be lots of reasons why a particular institution wants to implement a common canister protocol. And we've shown that it's feasible to implement with appropriate measures. Again, we've talked about those levels of disinfection not being well established, but it's been demonstrated by this study that it is possible to keep those RLU levels low with standard disinfection practices. And it is also feasible to monitor your disinfection practices through this RLU level. So that is a potential for people who are considering maybe going the common canister route or wanting to monitor in their own facilities. And with that, I'm going to turn it back over to you, Mr. Cappiello.
Jessica, thank you very much for that wonderful overview of the piece. And I saw Mr. Bayless's head nodding every now and then. Yes, it was well done. But Mr. Bayless, we have some questions for you now. We're going to put you on the hot seat. Well,
All righty, just be kind.
what were your reasons for doing this?
So the pulmonary lab at UC Davis is a separate department than the respiratory therapy. And the pulmonary lab has used the Common Canister Protocol for years, even pre-pandemic. And so the pulmonary lab, just to help reduce cost that's associated with that, was a big thing. And so we use these inhalers with spacers and making sure that they're the one-way valve spacers. And then during the pandemic, with all, especially the albuterol pharmaceutical companies, that were based mostly in India, closed down, causing that catastrophic shortage. And so not only were inpatient, but outpatient patients being really, truly affected this. And so the pharmacy and infection prevention and respiratory therapy and pulmonary were trying to figure out ways of how we can make sure that we still take our patients into consideration and how we can supply medications to them. So the Common Canister Protocol was developed or thought about again, and they were trying to figure out whether or not we could implement something like that hospital-wide. So there was limited research on this topic matter. Even when I worked with pharmacy and infection prevention prior to the pandemic with our Common Canister Protocol, very little research was available. Very little of it was peer-reviewed. Most of it was subjective. And so it was a perfect opportunity to do a little deeper dive into it. And so also UC Davis Respiratory Therapy and Environmental Services were using the 3M RLU or ATP measure already in-house. Respiratory therapy does surface swabbing on their ventilators, making sure that their ventilators are cleaned daily, and EVS uses the same apparatus and equipment and supplies for doing test surfacing on their beds. So measuring the potential for infection control, making sure that things are sanitized in a proper manner. And so also, Jessica had mentioned very eloquently, in the pulmonary lab, most of the things that we do are aerosol generating, let alone adding a aerosol medication on top of it. So it was putting our staff members at really high risk. So anything that we could do to reduce the aerosol generating mechanisms in our lab, thus allowing our ability to turn around to rooms on a quicker fashion and way. And so that's some of the reasons why I thought this work would be essential and important.
Excellent. All right. So next question. What obstacles did you anticipate prior to initiation of this project?
One of the biggest ones that I thought was going to be a hard sell was administration buy-in. And then my staff are very intelligent people. They want to know the hows, whys, whens, what we're doing and why we're doing it. So getting their participating and buy-in is essential. Trying to get something like this possibly publicated, and then also the associated costs and for the supplies. So it's not only that you have to purchase the device, measuring device, but the swabs can be quite costly as well.
So what were some of the unforeseen obstacles that jumped out at you during the study?
One of the biggest things that I had a problem with at UC Davis, and it probably was pandemic, but it's also because it's a large institution, is trying to get my IRB through UC Davis. It was a lot of back and forth. There were a lot of people that were probably working from home. There were people, that may or may not have been going on vacation. So, I'd put in, they would have me do some kind of change, and then I wouldn't hear back from them for a couple of weeks. And so just getting my IRB through UC Davis was one of the biggest ones.
It's a timely process, yes.
And then one of the things that happened too, because of, as we know, with supply chain issues, is that I actually had supply chain issues getting the swabs at one point in time. And fortunately, because respiratory therapy is using the same product in EVS, we were able to borrow from each other. So I would get a supply in and they would call me, and I would run out and I'd have to call them. So that was a huge thing with supply chain. And then the equipment annual calibration requirements. When we purchased this, I didn't realize that the equipment has to go out for annual calibrations. And if it's dropped or harmed in any way, it has to be rechecked, because of course you want equipment that is properly taken care of and making sure that your measurements are accurate.
So tell me about you had to have some pleasant surprises.
One of the biggest things, the supply, because I told you my staff are really particular, is I found out after I taught them, after I did my instructional piece, that some of the verbal feedback came back, and they came back with excitement. They thought this was going to be a complete waste of time. They thought it was waste of resources. They thought it was something that wasn't going to matter. And my staff are really sticklers for infection prevention. And when they realized what this could do for their daily use of, or their daily work with working with patients, and realizing that this is an apparatus, one more way of showing that this thing that we're doing is safe to our patients. And so they really bought in. They got really excited about the whole thing. They came into during the initial teaching, they came into my office with their tail between their legs, and they left with just this excitement and joy. And it was really an incredible thing to see them go through that process.
Congratulations on that.
Thank you. And then also the excitement from my advisors at Boise State. Jhaymie, it was just amazing how excited that you were about this project and how you helped me through this project. So I need to give you kudos and shout outs for that, for sure.
Okay.
And then the feedback that I got from my peers and during the capstone. And so it was just an incredible process. Not going into capstone, not knowing exactly what it was going to be and how much work was going to be entailed, and would I get lost in it, and it just was an incredible experience for me.
Excellent. Thank you for that. Well, you mentioned something about administration before. What specifically did you need help with administration for?
The devices was rather expensive, and then of course the swab. So I needed them to do buy-in. And once I discussed with my director of what I was wanting to do and the research, and it was 100% buy-in. I mean, just right from the beginning, because my director is also over respiratory therapy as well. And so, because they use the apparatus, she is very familiar with it, and she already knows about the project. So I had to do very little to convince her to allow this project to go forward. And then, my director, I have to give a shout out to her, Michelle Herzog. She's very forward thinking. She's very proactive, and she's always pushing respiratory therapy into the future with advanced roles. And so UC Davis is, very pro research. And so I'm very lucky to work in a large institute like this, where we may have a little bit more better funding for things. A lot of our residents and fellows are expected to do research. A lot of our attendings are doing research. We have a huge pulmonary attending group here. We're getting a lot of new blood in, and it's just amazing some of the stuff that UC Davis has the potential to produce.
Thank you, Rob. How about the results? How are you planning on applying these results?
Well, currently right now, I haven't put this in place. I've had a lot of other things that I need to do, and I need to present this to pharmacy and infection prevention as well. Policies need to be updated, and we need to come up with a mechanism between pharmacy and infection prevention of how often we're going to do this, how we're going to do this, why we're going to do this, what we're going to measure. Jessica had mentioned during her speaking that about the RLU levels. And so for the project, we set the RLU level for pass and fail at 250, and that was a manufacturer recommendation. So anything below 250 was a pass, and 250 and above was a fail. And so if I don't remember if you remember the data, but the RLUs, except for those two outliers, they were in the 40s and the 50s. So the staff were really doing a great job of doing infection prevention with the hospital-approved wipes that we had. And we did have those two failures. And what interestingly was it was the same staff member and it was the same wipe. So, I don't know what happened with that, but it was just kind of interesting. Everything else was way below. I mean, rarely was anything above 100. And so, and also too, because we were doing the project, it made the staff more aware that the project was going on. So did they use and spend more time on sanitizing this product? Possibly, because they knew we were actually doing measurements for it. So, if it once it's implemented, they would be more aware that we are doing measurements. Would be a real-time measurements where if the product has an RLU over 250, that's what we go by, that they would take that product out of production or out of use, re-sanitize it and remeasure it. And so it gives us real-time capabilities to keep track of these drugs and devices that we're using regularly.
Rob, Jessica has a question.
I was just going back to the RLU levels and trying to, come up with an interpretation for what is considered high, what's considered low. I'm curious if you have any data from the other swabs that you said were going on at your hospital, like when they swab the ventilators for disinfection status, what kind of RLU levels are they getting on those, or on the beds that EVS is testing, just to see like what the comparison is between other things that we are testing and these MDI canisters.
Yeah, that wasn't really part of the project, but when I did discuss with them, they generally are following the manufacturer guidelines of 250 as well. And so they do the same thing where they, the ventilator surface areas of what they're using in respiratory therapy, because especially during the pandemic, what the respiratory therapist has to do on each shift is wipe down their ventilators of what's being used. Because a lot, as we know as respiratory therapists, on that surface, everybody puts stuff on that. Medications go on that. Nursing puts a lot of stuff on that. Yank cars go on it. Physicians come in and put their stuff on it. So making sure that that surface on that ventilator is being wiped and sanitized. And what they do in respiratory therapy is if it's above it, they track it and see if they're having problems with that same staff member possibly, or that kind of stuff. I don't know how much problems that they're having with that, but I would imagine because it's not the staff that are swabbing, it's the supervisors going out and swabbing. So their staff are super aware that this is being taken care of. So it's making them aware that there's oversight.
I think having that oversight is a really important part of this because, as we know, things get busy and it's easy to just go, oh, I'll put that off till later, or I'm not going to take it that seriously. But if you know that somebody's watching you, right? If you know that there's going to be some follow-up, even though we hope everybody's doing the right thing when nobody's looking, right? Having that monitoring definitely helps, I think, with
absolutely.
adherence to these correct practices.
Okay, Mr. Bayliss, what did you learn from this work outside of your results?
The level of time and commitment to get it done, to bring research from the start and to the completion. It made me really respect a lot of the information that's out there. It takes a tremendous amount of time, and I did it as a master's student, and I had limited time, but to bring these studies that sometimes takes months and years to fruition, and then to get it published, it was just almost overwhelming looking back. I don't know how I did it, especially working full-time plus and managing two very busy departments. But if I could get it done, if I could do it with what was going on in my life, I push my staff and anybody to listen to me, not only to develop their education and increase and making respiratory therapy progress and move into the future, but also to do research.
Thank you, sir. All right, now this is, I think, the last question we got. How do you think your results apply to the use of Common Canister Protocol outside of a diagnostic unit?
One of the big things that would be challenging outside of a more controlled environment like the pulmonary lab here at UC Davis is, let's, for example, that we have a busy, really busy, all of our units here at UC Davis are really busy, but it's not only respiratory therapists that are distributing medications to the patients when it comes to inhalers, nebulized treatments, that kind of stuff. So it depends on staffing. So you could have a lot of people touching those meter dose inhalers. And because of that, you don't necessarily know what they're doing in between. Are they following practices? Are they using hospital advice? We know how busy nursing can be. We know how busy pharmacists can be. And, we use the Pyxis here at UC Davis for medication control. So not only the pharmacists are in those Pyxis, but then we have pharmacy techs that are in those Pyxis. They're looking for expirations. So there's a lot of potential touch on those medication devices. And so it would be really a little bit more challenging, not that it couldn't be done, but it would be more challenging to do it in a less controlled environment. In the pulmonary lab, it's just respiratory therapists. We have one Pyxis. Yes, the pharmacy comes down and checks our expirations and all that kind of stuff, but it's a lot more controlled and with a tighter oversight.
Thank you, sir. Oh, yes, this is the last question. How does this experience impact your perspective on your current role?
I have to say that it really, lit a fire. I've been a respiratory therapist for a very, very, very long time. And so just seeing the progression of our field, the pandemic was horrible, but one of the benefits that came out was now people know who respiratory therapists are. And we were always, or I don't know about your guys' experience, but when I went to a bedside, if I was going to bedside, I was either called a nurse or a physician. And so, but now the public knows, at least in the United States, who a respiratory therapist is. And so, it really lit that fire. It built excitement. It had built excitement in my staff. They're critical thinkers anyway. And so just being able to bring that enlightenment and that joy to our field again, where yes, a respiratory therapist can do research. Yes, a respiratory therapist can have advanced roles. That's not part of this project, but there's just so much opportunity that is happening in our field from state to state to state, and it's just incredible. And then also, incorporating technology in our field. This piece of equipment is not something that I would have thought to use in a pulmonary lab. And because this technology is used throughout the hospital system, and here we are discussing it, other people that may not be aware that some of this technology is available could possibly bring it into their own facility and have safer ways of sharing medications like we're doing.
Well, thank you, sir. And with that, open floor. Whoever has a question, go ahead, chime in. Unmute yourself and chime in.
Lanny, I see you have a couple comments in the chat. Would you like to speak?
So, my question is, I think twofold. I'll make a comment and then I have a question. I think my challenge is that we went all or none, especially in where I'm at, with MDIs went away, right? So there was this cost analysis by pharmacy that said we're wasting inhaler because it's not clean to do common canister. I think what you've shown is there is a potential to come back to that. But my question is how do you encourage your staff to solve other problems or challenges? And then how do you get them to ask the tough questions and then want to do the research?
My staff are very inquisitive. If they do not understand something, they demand an explanation, not only from me, but also from our providers, our medical director. And so they want to see proof. They want to see something. They don't want to hear conjecture. And so when when they see this, and they see this happen day after day after day, where myself as a leader, my supervisors as leaders, and we're saying the same thing over and over again, and we're walking the walk, and we're talking the talk, and we are still participating as much as we can in their daily work with these patients. And so the respiratory therapists that are under my umbrella, in my pulmonary lab, they are allowed to be more than just a tech that pushes buttons. They teach. They do not only teach the patients, but the families. They go and do invasive and non-invasive procedures. We do cardiopulmonary exercise tests. We do sputum inductions. We do all kinds of stuff, not only with our pediatric pulmonologist division, but adult pulmonary division. And they also work in the clinics. They go and see different environments, and they get to do different things there with biologics. So there's excitement, and and they see progression in our field, and that's brings them joy and happiness, knowing that they have especially here at UC Davis, they have a career ladder if they choose to use it.
I think that's so important. Honestly, it's the culture at UC Davis, I think, that really allows this kind of research and inquisition to really flourish. And I think that's one of many amazing things that you guys have going on over at UC Davis.
Well, if there's no more questions, I do want to, of course, I can't stop talking, right? Anyway, I want to applaud you, Rob, because I really hope you publish this, or hope it gets published, because it answers something that is a current theme in this Common Canister Protocol, in this battle of use a Common Canister Protocol, use nebulizers. The facts are it costs more to use a nebulizer. The fact is, if you throw out a canister that's not empty, you're wasting medication. Well, we have no comparative study out there to say 4 nebulizer treatments cost more than 4 MDI treatments. Well, we have enough information to say that nebulizers are more expensive. What we need to do is have work like this published to say, yes, Common Canister Protocol is not a bad thing. If it's done properly and we do more research on it, we can actually create standards. When we're disinfecting the actuator, whether it be with alcohol or a Cava wipe, these actuators are not coming in contact. So if we had a regulatory agency say that disinfection is fine, Common Canister protocols would be in that umbrella, but we don't have those standards right now. So by you doing this work helps get us one step further, especially if it gets published, helps get it one step further where it can be an accepted practice. I know inhaler companies are doing a good job trying to make these hospital-friendly inhalers where they have 60 actuations, and that's a cost savings. But if we look just at switching to nebulizer therapy, like Lanny mentioned, we then lose the ability to teach patients proper use of the inhaler. And that is a big issue. I want to quickly, for those of you that are here, I'm going to quickly jump back. I want to highlight this piece, this article by Kondo, Austin, Akel, Aurora Press, estimated cost savings from optimizing use of inhaled medications for inpatients with obstructive lung disease, came from the Journal of Asthma in 2023. For those of you that are listening, write that down. There was a large number of patients that they looked at, 552 adult patients. So that's quite a lot of treatments. If they got 4 treatments each, that's close to 2,000 treatments. They concluded that transitioning from nebulizers to MDI is an ideal approach because they considered what we want with best practice. We want to see the patients use their inhalers. We want to make sure they're doing it properly. We want to discharge them for success. If we give them nebulizer therapy only, we're not. Plus, we're also increasing the cost of respiratory therapy. Pharmacy may be happy on their end, but now we're robbing Peter to pay Paul, and that may not be best practice. So it's an individual institution decision, but I think we need more evidence, and I think evidence like what Mr. Rob Bayliss has pointed out can help bring us that much closer. So I guess this wraps up Jess, what do you think?
Yeah, I think this is a good place to close. Thank you so much for being here with us, everybody. It's a good discussion.
I hope you all have a safe and happy Halloween.